Thank you very much for allowing me to speak today about low birth weight infants and congenital heart disease. I have no relevant financial disclosures. The objectives of my talk today are to discuss the risks low birth weight babies and prematurity pose for neonates with congenital heart disease, and discuss the risks and benefits of delaying cardiac surgery versus going ahead and doing early cardiac surgery shortly after birth. So we've seen in congenital cardiac surgery, since I've started practice, tremendous improvements in mortality rates for children with congenital heart disease. In the current era, in the United States at least, the mortality hovers between 2 and 3%. And importantly, we've seen the drop in mortality for the highest risk categories, patients who were born with problems like hyperplastic left heart syndrome or truncus arteriosus, dropped from over 50% in the early 80s to somewhere around 10 to 20% in the modern era. That improvement in survival is primarily driven by changes in cardiac surgery for older patients and term newborns. If we begin to look at what are the risks for premature infants, the risk of mortality is substantial. This is looking at the creation of the STS database and risk stratification. And the patient factors that the surgical group added were age at less than 1 month or over 1 month and a weight criteria. And if your age is less than 1 month and your weight is less than 2 kilos, your risk of dying goes up by almost a factor of 5. That's shown in the red box. And even if your weight is between 2 and 3 kilos, you still have a substantial increase in mortality. Looking at a single center study in a more modern data set, this is a study looking at 171 low birth weight babies and or premature infants born at less than 37 weeks compared to 342 control babies. And they were matched for diagnosis and procedure and year of operation. It excluded babies with PDA ligation, ECMO, or pacemakers, and the operation had to occur in the first year of life. And in this slide, first of all, the top diagnoses are all children with complex congenital heart disease. These are children that are not going to necessarily get out of the hospital without an operation. 20% had transposition, 10% had arch hyperplasia of one sort or another, 10% had hyperplastic left heart syndrome. And if you look by operation or diagnosis, mortality is reduced in almost all cases, whether it's a bypass case or a non-cardiopulmonary bypass case. But as you can see here, even in simple coarctation, there's a 13% mortality versus none in the term infant group. Even a VSD, another operation that should have essentially zero mortality, there was an 8% mortality seen. I like to show this graph because it shows sort of the mortality risk based either on gestational age or weight. And as you get to around 35 weeks or around 2 kilograms, your risk of mortality goes down, or your chances of survival goes up substantially. So that seems to be an inflection point. And this is similar from other data sources, including the STS database. Complications, on the other hand, sort of follow a linear pattern with, as your gestational age goes down, your complication steady rate goes up. Similarly, as your birth weight goes down, your complication rate goes up, including things like ECMO or need for unplanned surgical reinterventions or the development of pyelothoracic. As Mary showed in the last presentation, even 37 weeks is too early. This is a study from the STS database about a decade ago, looked at 4,700 patients although there were almost 10,000 patients in the database, 48% of those patients were born before 39 weeks. As Mary showed in her talk, being born at less than 39 weeks is associated with an increased odds ratio for mortality that goes up substantially, as well as an increased risk of complications and a longer length of stay. So shooting for 39 weeks is what we aim for. It is complicated by the fact that if you have a complicated neonate or a neonate with complicated congenital heart disease, who's going to need to have a surgical team on standby, a cardiac ICU team, potentially a catheter-based cardiac interventionalist team, a special delivery team, neonatology, trying to coordinate and make sure the mom doesn't go into spontaneous labor before 39 weeks, complicates this equation. So why is it so much harder in premature infants? Why is their mortality risk so much higher? Well, first of all, there are technical considerations. Even the simplest operations are going to need a technique known as hypothermic circulatory arrest, and I'll show you why in a second. That is a much more harsh technique in terms of an infant's tolerability of it versus cardiopulmonary bypass. There is difficulty in sizing the shunts and bands that we might use to palliate a small child. We can only reduce the size of our shunts to a certain level. And our techniques remain in flux. We're not happy with our mortality risks. These patients are with the highest risk groups are rare within a single institution. And so there are things that change over time, and we don't necessarily know whether those changes are going to be good or bad for our patient. And then, of course, there are the patient factors that you all are aware of in terms of the organ immaturity and tissue fragility. Cardiopulmonary bypass is obviously a big stressor to the body. It is sort of what I would characterize as a mini sepsis episode. There's complement activation, there are activations of multiple inflammatory pathways, as well as ischemia reperfusion injury, particularly to the myocardium. And this leads to both endothelial and myocardial dysfunction, as well as potential injury or stress to other organs. But I'd like to show this picture. This is a picture of a VSD closure in a 6-kilo child. And the things that you're seeing on here, here's the ventricular-septal defect in the middle. This is the large hand of the cardiac surgeon. These are forceps. This is a cannula to provide cardioplegia. This is an arterial cannula. This is a venous cannula in the SVC. Behind here is an IVC cannula. This is a left atrial cannula to keep bronchial collaterals from filling the field with blood. Obviously, you can't get all of this in to a baby who weighs 1.6 kilos or 2 kilos even. And so the only way you're going to accomplish this simple operation is to put in a single cannula into the right atrium, single cannula into the aorta, cool the baby down to 14 to 7 degrees Celsius, cool the entire body down, and then stop the cardiopulmonary bypass circuit and remove all of the cannulas to do your operation. This is a technique known as deep hypothermic circulatory arrest. And really can be conceptualized as whole body ischemia at a cold temperature for somewhere between 40 and 60 minutes. And in addition, operating a 1.6 kilo heart, you're going to have a lot more tissue fragility and inability to hold sutures, etc. And it is associated with both long-term and short-term morbidities, things like acute kidney injury in the cardiac intensive care unit during the recovery period, as well as concerns for a higher incidence of seizure. The other big technical consideration is sizing shunts and bands. A typical size shunt, aortopulmonary shunt, somebody who needs increased pulmonary blood flow for a term newborn is 3.5 millimeters. Will occasionally go down to a shunt of 3 millimeters in diameter. Any smaller than that, the risk of thrombosis goes way up. Similarly, trying to band or reduce pulmonary blood flow with some sort of flow constrictor is also very difficult in smaller babies. So that means that we're likely to overshunt or not reduce the pulmonary blood flow to the lungs in a fashion that's going to allow the baby to grow. And so we're going to give the baby congestive heart failure. And with the congestive heart failure, there'll be poor growth because a lot of the calories that would otherwise be for growth are used to pump blood. Often these babies will end up returning to mechanical ventilation because of decreased lung compliance and pulmonary edema. And with large volume overcirculation, you can induce pulmonary vascular disease. And if we look at contemporary data in the United States, looking at from a critical care sort of data set, the mortality risk for a pulmonary artery or aortic pulmonary shunt in a term infant is 4.5%, with a fourfold increase to 16% in preterm infants. And these are preterm being defined as less than 37 weeks gestation, and not even the small premature infants that we sometimes see. And then there are patient factors, including CNS immaturity, immature lungs, kidneys, a risk for enterocolitis that is independent of your gestational age, and then the long-term consequences of living in a hostile environment. And I would submit that the CICU, in terms of neurodevelopmental care, is a lot more hostile than a NICU is for a large variety of reasons. I'm not going to talk a whole lot about this. I did want to highlight an issue about CNS immaturity, because in congenital heart disease, I really have changed my focus and thought about thinking about congenital heart disease. It's really congenital brain and heart disease. And the reason I've changed my focus is a graph like this. When you look at children who have moderate or severe or complex congenital heart disease, those children who are going to end up in the cardiac ICU for a long period of time, very few, in severe disease, only 30% versus 25% of children will escape sort of their cardiac palliation course without any neurodevelopmental issue. The large majority of the complex children will have neurodevelopmental issues, and these can be quite subtle. I was reminded of a patient of mine who I just saw in follow-up who had done very well all through high school until last year when he was a senior in high school. And because of virtual learning, he essentially failed his final semester of high school and actually had to go to summer school to complete high school. So very few, and it can be subtle. Why does this happen was both a combination of changes in fetal blood flow. We all know that placental blood is in fetus with a normal circulation is directed towards the brain. But if you've got a child who has a mixing lesion, such as hypoplastic left heart syndrome, you're going to mix deoxygenated blood from the brain with oxygenated blood from the placenta, lowering the oxygen content and the oxygen delivery to the brain. And in patients with detransposition, it's going to be very blue blood going to the brain. Does that translate to abnormalities? Absolutely. This is a study looking at brain volume as assessed by MRI. And as you can see during the open boxes are children with congenital heart disease. And as you can see in the third trimester, their brain doesn't grow as rapidly as a child without congenital heart disease. That can result in a bigger risk for preoperative brain injury. We also know that brain maturity is delayed in children with severe congenital heart disease. This is looking at an index of brain myelination, again, as assessed by MRI. In this dark gray box, on the left-hand side is children born at term. In the middle box is children born prematurely at 36 to 37 weeks without congenital heart disease. As you can see, their brain myelination is delayed. And then finally, in the white box on the right-hand side are children born at term with congenital heart disease. And their brain myelination is similar to that of a 36-week gestational age infant. So their brain maturation is delayed by approximately a month. And we know that those children will have preoperative lesions. Approximately 1/4 of children with either hypoplastic left heart syndrome or detransposition of great arteries will have preoperative ischemic lesions. Some of them will have hemorrhagic lesions. And with the consequences of bypass, 3/4 of them will have new or worsened lesions. How does all this immature brain stuff factor into our treatment decision? And it really is a question, for me, is prolonged cyanosis, prolonged congestive heart failure better or worse than an early exposure to cardiopulmonary bypass? And importantly, does early cardiac surgery really shorten ICU stay and shorten lack of neurodevelopmental care, or is it just accompanied by long postoperative stays? And these are questions that are still not clearly answered in the literature or even in our own practice. Let's talk a little bit about treatment strategies and primarily when to operate for cardiac surgery. So this is the paradigm. I mean, it's easy to understand. You want to operate when the probability of mortality or morbidity is lowest. And if we graph age or weight at the bottom, we want to operate where the big red arrow is. But one of the questions is it what or when? Is it a certain gestational age or postnatal age, or is it a certain weight? We'll talk about that in a second. But more importantly, the conundrum is how to get there. How do you get to a certain age or a certain weight with a patient who is an optimal candidate for surgery? If you require 1 month of mechanical ventilation and your patient is anosarchic and has had intracranial hemorrhage by the time you bring them to surgery, or 3 or 4 episodes of necrotizing enterocolitis, I would submit that that is not an optimal candidate for surgery, and that waiting, you may have waited too long. Here's a quick patient example. We have a baby with critical aortic stenosis who's born at 31 weeks, weighing in at 1.2 kilos. The infant is treated with prostaglandins to keep the ductus arteriosus open. It's on day 1 or 2 of life. The infant looks pretty well. It's got a 90% saturation on room air, not needing any additional respiratory support at the moment. What do you do with this baby? We could medically manage them to allow patient growth and organ maturity before definitive repair. That essentially means in this infant continuing prostaglandin. In the particular example I provided, you could do an aortic balloon valvuloplasty that may be curative or at least definitive for a while if the morphology of the valve is appropriate. But even if the valve isn't appropriate for balloon valvuloplasty, you might get some relief of stenosis long enough to allow the baby to grow and come off of prostaglandin. You could do a definitive complete repair with a valvuloplasty or a surgical valvuloplasty or a neonatal Ross procedure. So these are the options. The data for specific lesions overall is very variable and again remains in flux. What are the different disadvantages? Why operate early versus late? Well, arguing against delay is you have complications of prostaglandins, including apnea and peripheral edema. If the patient is in heart failure, that weight gain that you're trying to see is difficult to achieve because of the abnormal physiology. If they're cyanotic, you're exposing organs to prolonged cyanosis. And then you have all of the ICU-associated morbidities, particularly for access. And access becomes very important in children with congenital heart disease, particularly those children who are going to need multiple operations. So, and particularly those children with single ventricles, because deep venous thromboses can affect their candidacy for subsequent operations. And then there is attrition or mortality prior to the operating room from all of the ICU morbidities that we know well, including sepsis and necrotizing enterocolitis. The argument against early surgery is the technical issues, the immature organ systems, the abnormal chest wall mechanics that are going to occur after you split the sternum or perform a thoracotomy, which may result in long-term mechanical ventilation. And then there is a higher surgical mortality risk. I must say that in my field, there's been a bias, I think, towards early intervention and early surgery. This is just one of the first studies that sort of tried to answer that question. This is a paper looking at the consecutive 100 infants born at less than 2.5 kilos at a single institution. 62 of whom have had early intervention with a mean operation at 9 days with 81% survival to hospital discharge. There was a group of 26 infants who had a late intervention with a cumulative survival to hospital discharge of 69%, with most of the deaths actually occurring before they had intervention and typical ICU sort of issues in terms of necrotizing enterocolitis and sepsis. More modern series looking at, again, a single center study looking at infants having an operation at less than 3 months and less than 2 kilograms. The group that got delayed surgery had an average growth of about 95 grams. There were differences between the groups of children who got delayed versus earlier surgery. The delayed surgery group tended to have right-sided obstructive lesions or right cyanotic heart lesions like metrology of flow, while the early surgery group tended to have lesions that obstructed systemic blood flow. The birth weights and the gestational ages were younger in the delayed surgery group. The time to surgery in the delayed group was 2 months. And what was important outcomes for this paper is that the complication rates were much higher in the delayed surgery group as would be expected, but there was no difference in hospital mortality. So that delay might be useful in individual cases, but you may not improve the survival of the patient overall. Looking at the question in a different way about whether you should grow a baby or operate, as opposed to this is a multi-center study looking at a critical care data set, C4, again, a relatively early era. All of the infants in this study had a birth weight of 1.5 kilos at birth, so very small babies. All of the babies had their operation at less than 2.5 kilos, and the outcomes were, or the groups were stratified by weight at surgery. Infants weighing less than 1.5 kilos versus 1.5 to 2.5 kilos at surgery. And, the median age at surgery between the two groups was 14 days for 53 days. And the results were interesting. there was no statistical difference in survival overall, or whether you divided the patients into subgroups such as one ventricle versus two ventricle repairs, or those infants requiring cardiopulmonary bypass versus no cardiopulmonary bypass. Additionally, there was no statistical difference based on diagnosis, but the ends are very small, and I think are very telling just looking at the raw number. If we look at patients with hypoplastic left heart syndrome, if you had your operation at less than 1.5 kilos, there were 7 infants with 1 survivor versus a larger infant where the 6 out of 9 infants survived. Similarly for TAPVR, autonomous pulmonary venous return, 1 survivor out of 2 versus 7 out of 9. But I think that, particularly for infants with left-sided obstructive disease, operating at a very, very early age may not be the right thing. And at our own institution here, we've adopted a strategy for these very small babies, in particular for hypoplastic left heart syndrome, that is not a definitive repair. We perform bilateral pulmonary artery banding and then continue the babies on prostaglandin and either then do a delayed Norwood procedure, which is an arch reconstruction and reestablishment of pulmonary blood flow, or a hybrid procedure with a PVA stent. Finally, the question that comes up of whether you do a palliation or you do a full repair, for example, in a patient with tetralogy of Fallot. The debate centers around that shunts and bands are hard to get right, particularly in the smallest infants, and then you have a need for another procedure. And a full repair is not necessarily more dangerous, both in single-center studies and multi-center studies suggest that a full repair is as efficacious as a palliation and then repair. With that, I'll close my talk. My summary statements are prematurity and low birth weight are very important risk factors in babies with congenital brain heart disease. 39 is always better than 37, and both are better than anything less. Early versus late surgical intervention remains a revolving question, and intervention needs to be tailored to the individual heart disease and the patient. I did not really discuss all of the other risk factors and non-cardiac risk factors that we often see in these patients, including congenital diaphragmatic hernia, GI anomalies, and congenital syndromes such as Down syndrome or DeGeorge. With that, I thank the organizers for inviting me to speak today.